Welcome, everyone. Welcome to our first session of our Decolonizing Global Health series titled Colonial Entanglements and the History of Global Health. I really appreciate everyone taking the time to join us today in what's going to be a really exciting topic and a timely topic. And I know there's a lot going on in the world, so we appreciate you coming here to join us. My name's Parmi Suchdev, and I'm a professor of pediatrics and global health at Emory and associate director of the Emory Global Health Institute. For those of you not familiar with the Global Health Institute, one of our mandates is to really convene players in global health across Emory's campus and outside of Emory. And as part of that, we host a regular Global Health Forum series to discuss timely topics in global health. Sorry. And so we picked this, this topic really as a result of a lot of interest from our prior participants in our global health forums. Probably one of the most common requests for topics was on the issue of colonialism. And we really heard a lot from our students as well. And so we're doing something a little bit different. This is going to be a 5-part series. And so our first one is today. And then we're going to have several in 2021 in January, February, March, and April. And we're going to have a second one that's also going to follow up on this session and address the role of religion on the history of global health. And then our final 3 sessions will be on kind of the active decolonization process in terms of global health practice. We're going to talk about decolonizing global health research, decolonizing global health education, and decolonizing global health service and missions. And why are we doing this? One is to increase awareness of this topic, but we also want to have some direct impact and changes that come out of this in terms of global health curriculum here at Emory and other academic centers, changes to global health policies, for partnerships and the way we engage in global health work. And we're also planning to put out some seed grant funding to faculty to address research gaps. And we hope those of you within Emory and even outside of Emory can use some of these lessons and implement some of these changes in your own institutions as well. And the way we're going to do this is, unlike a typical webinar that's usually just about an hour and a half, we're going to have 2 parts. So there's going to be a panel discussion which you're all participating in right now. And then this evening, we'll have a breakout session that'll go into a deeper dive into the readings that were assigned in advance. We want to make this a more active process. And finally, I'd really like to thank our planning group members. We have several faculty, students, and staff across Emory. And in particular, I'd like to thank our Emory Global Health Institute Student Advisory Committee presidents, Anupama and Alice, who have really been the drivers of this and really asking those of us at faculty that this is a topic that students really want to learn more about. So we thank them for their leadership and their initiative. And before we also begin, I'd like to take a moment to acknowledge the Muskogee Creek people on whose land we are living, learning, and working. And wherever you're located, we encourage you to learn more about the importance of ancestral land acknowledgement. I'd like to now turn it over to our moderator, Dr. Doug McFarland, who's an associate professor in the Hubert Department of Global Health here at the Rollins School of Public Health. She'll introduce our panelists, and following their presentations, we'll have a moderated discussion using the questions many of you submitted when you registered for this event. You can also enter your questions in the Zoom chat function, or sorry, the Zoom question and answer, and we'll try to get to these if time. So our esteemed panelist, Dr. McFarland, is really an icon here at Emory, both in terms of her expertise as an economist, but also as an educator. She's been involved in health policy and health financing issues for the past 35 years with a particular interest in interface of disease control programs and health systems. And she's a renowned teacher and the recipient of the highest honor for teaching among all schools of public health in the US. So I'll turn it over to Dr. McFarland.
Thank you, Parmi, or Dr. Suchdev. An icon, I'm not sure about that, but let's move on. My name is Deborah McFarland, and I have the honor of moderating this session today as the first of the series on decolonizing global health. Both terms, decolonization and global health, are fraught with theoretical, conceptual, political, semantic difficulties. Academics, activists, health practitioners, and others, primarily led by students throughout the world, really, and certainly here at Emory University, are working to minimize long-standing power imbalances in the global health arena, most of which took root in the colonial era. We see colonialism's influence everywhere in global health, from the current responses to the coronavirus pandemic to endless boardroom presentations and discussions in Geneva, in Washington, D.C., in London, and yes, in Atlanta, to Ebola treatment wards in the Democratic Republic of Congo. Just as an example, when the London School of Economics advertised for an African health systems expert to be based in the United Kingdom in February of this year, Twitter went ballistic, and it prompted a discussion around the hashtag decolonizing health policy and systems research. Global health needs integrated, decolonized approaches that address the complex interdependence between histories of imperialism with health, economic development, governance, and human rights. And this global movement to decolonize global health is one movement in that vision. Randy's going to tell us, Dr. Packard is going to tell us about the historical roots of global health and in the European, particularly colonial endeavors, and in imperial interests. Just as those reflected the unequal power relationships of their time, global health reflects the unequal relationships of the present. With few exceptions, global health departments in Europe, in North America, including Emory, seem to be the place to do research on low-income, formerly colonized countries in often apolitical, ahistorical, and uncritical ways. Our session today is the start of a university and, we hope, a community-wide dialogue on decolonization and its implications. Our first speaker today, Mr. Garang Piol, who I'm happy to say is a Foege Fellow in the Rollins School of Public Health at Emory University, a current student, and a recent graduate of the Masters in Development program, both here at Emory, is going to share his life with us. A life begun and lived in the brutal reality of colonial power struggles and their aftermath. Rather than me reciting his biography, Mr. Piol, Garang, will tell us his own story. Our second guest speaker, Dr. Randall Packard, Randy, is professor of the history of medicine at Johns Hopkins, where he holds a joint appointment in the Department of International Health, and he's co-editor of the Bulletin of the History of Medicine. Before he took up his current position at Hopkins, he was on the faculty here at Emory in the Department of History and in International Health, and directed an innovative center called the Center for the Study of Health, Culture, and Society. Dr. Packard's own journey in global health and his acclaimed scholarship will frame the colonial entanglements of international health through the lens of history. At the conclusion of the presentations by Mr. Piol and Dr. Packard, we will have a moderated discussion that draws from many of the questions that several of you submitted while registering for this event, and that will be followed by a Q&A from the audience. So if you will, please type your questions in the chat box, and I think Britton and Dr. Suchdev are going to monitor those for me. So let's get started as soon as possible, giving our two illustrious speakers as much time. So please welcome Mr. Garang Piol. Garang.
Thank you, Deb, and thank you everyone, for this opportunity, and also, talking about this buzzy word that carry a lot, as Dave has already mentioned. So I am going to briefly talk about the brief background of South Sudan, as well as my own life journey. So as Dave mentioned, my name is Garang Puk, and I'm from South Sudan. Next slide. For those of you who don't know South Sudan is one of the countries in East Africa. It's, I think it's about 2 years now since it's joined the East African community. It's, you know, as you see in the map, it's being bordered by the 6 countries. And, you know, that's the South Sudan. Next slide. Before South Sudan became a country, it used, you know, to be one country, which is, you know, known as Sudan by then. And Sudan, before, you know, independent in 1956, it used, you know, to be under the 2 colonies. The southern part was actually under the British colony, whereas the northern part was under the what was known as Anglo-Egyptian colony. And so in 1956, when it became, you know, when it became independent, the British, you know, handed over the stick, you know, to the northern part, which was, which is, and still, you know, which was and is still, you know, predominantly, you know, Arab country. And so immediately, you know, the northern part took the power, nothing has changed. And so the southern part, you know, the southerners felt, you know, nothing has changed, and they felt, you know, like they are still not being, you know, they are still, you know, like being colonized. When, you know, there was declaration of, you know, of independence. And so in immediately, you know, under the after the independence, the southern part, which is, you know, like it's mostly, you know, black people, or, you know, known as Sud also. Sudan is actually, you know, like from the word Sud, and Sud is, you know, Sud mean black. So took up the arms in 1955. And that lasted until 1972, when there was the agreement signed. And the agreement actually gave Southerners a self-autonomy. And that self-autonomy, you know, took, you know, it gave them, you know, relative peace until 1978, when British company actually discovered the oil deficit in southern part of South Sudan. And as soon as, you know, the oil was discovered, the northern part started, you know, stripping off, you know, the power from the source. And as a result, in 1983, the Southerners again, you know, like took up the power, and that, you know, lasted until 2005, when there was a comprehensive peace agreement signed in Kenya. And as a result of that, there was a referendum which followed later. And the referendum was in 2010, where almost every South Sudanese voted, you know, to have their own country. South Sudan was born then in July 2011. Sadly, you know, following the 2 years, the country, you know, like got itself into what it is still in now. There was an outbreak of conflict, and all this, you know, it has something also to do with the past history. So there was an outbreak of the conflict, and it is estimated until now that, you know, about 2 million people are internally displaced. You know, they have been uprooted from their own country, I mean, from their own villages. 2.2 million or more are actually, you know, seeking refuge in neighboring countries. The situation is still, you know, horrible. It is estimated that, you know, like about 76% of the population, you know, goes without food. And, you know, South Sudan is inhabited by about, you know, 12 million people. Next slide, please. Yeah, so now, you know, every history has, you know, the bitterness. And when always, you know, there's a war between, you know, the power, you know, like the parties that are struggling over power, the communities are always, you know, caught in between. And my community was not exceptional in this. So in 1973, we fell in between. And, you know, our community was perceived as, you know, one of the communities that was supporting the rebel. And during May 1970, you know, 1983, 1984, there was, a surprise in the morning that, the village was engulfed by those in military uniform. And as a result, there was a lot which happened in that village where, we lost people, lives were lost, property were lost. Everything was actually, burned down on the ground. And so that was, the dark part that, stuck with me. And the picture here is not really, it doesn't reflect, 1984, but this is one of the villages, which has been, it was under, it was recently, burned down. So this is what is still happening in South Sudan. Press. Yeah, so that's what I've talked about it. Yeah. Next slide. Yeah, because of what I've seen, in the village, seeing my own close relative, being massacred, and we lost everything. That is stuck for me, for about 6 years. And when we realized that like the SPLA, the movement which was formed during that time, South Sudan People Liberation Movement, South Sudan People Liberation Army. So when when we heard, like when communities heard that the movement has its base in Ethiopia, everyone was like rushing to Ethiopia just to get gun. So I was one of the people, just because of what I've seen. I thought the only thing I could do is also like join the army. And so my home area is actually from the northern part of South Sudan, that is northern Barghazal. So I took a 3-month journey. I think I was about 11 years old, to Ethiopia, where I got trained. And after the training, I came back to South Sudan. And so this was a horrible journey, but because of what I've seen, I felt I was doing the right thing. So next slide. And after going to Ethiopia, undergone training for about 9 months, I became a child soldier, and started having guns for a period of 5 years. And maybe as some of you are aware, like when children have guns, always it's not it has its own downward, using having used gun as a child. Some of the things that I was doing, there was no there was no thinking behind what I was doing. And as a result, every day was full of it was, every day is a dark day, because you see your own colleagues being you are losing all your own colleagues, as well as not just your own colleague, but also like what you are doing, you're also, I was trying to do the revenge, but whatever I was doing was not really a revenge. You see whatever you're doing on the other side, you're also doing more harm than what than what you are doing. You end up seeing that the people that you are fighting are as innocent as you are. So I used the gun for a period of 5 years, and in between I got someone who was really knew why he was fighting, because he's not the person who just wanted to satisfy his his quest. And he started like changing my perception of who I will be if I'm indicated. So he convinced me. It took us some time to realize that if I leave being a child soldier and go to school, I can be helpful to my own community. So in 1995, I accepted, and then left left the army, and he facilitated me, and that's where I started education when I was about 16 years old. So I started going to school during that time. Next slide. It was not an easy journey, and during that time, I think for those who have been in South Sudan, if I told you where, or Sudan during then, every day was full of mysteries. So there's no, though I was going to school, there was no there was no stationery. It was about anything that you write, you just write it on the ground. This was one of my teacher, was called Piol. If you see, he doesn't have one of the hand. One of the finger, actually he lost it. He was an army before he when he was wounded, he became a soldier. This was one of my colleagues. And that's, how education was. But regardless of, the person who facilitated me, to go to school, I was determined, to finish. And that's how, the journey for transformation started as individual. Next slide, please. Yeah, and after that, I think how I end up, to be at Emory. It's also, it has its own, history behind, and maybe I would, if you really want to understand, I think there are articles that are written, and you can, search one of the article, and you can, get to know more about me. So I was helped, by a group of people that helped me to be at Emory here. And so it took every effort of everyone, to help me get to Emory. Next slide. Yeah, so as we start, talking about this buzzword, decolonization, I think, we first, where, I think what we need to do is start asking ourselves, where are we really going to begin it? Where do we begin? And I think as individual, looking at the history and looking, where I came from, anything that we do always, has a past, associated to it. And if we really wanted, to start talking about, decolonizing global health, then, we don't need to look, from very far. I think we need, to start seeing how do we really, shape our programming. That's, one of the parts that we need to look, how is the programming done, in public health? Whose interests are we meeting, if we start talking about, the decolonizing, the global health? Are we really meeting the interests of the communities? And if we are meeting the interests of the community, how are the projects designed? Are they designed to capture the the interests of the communities, or are we only as a global practitioners trying to really legitimize this multi like the donors that funded global health program? I think that's, we need, not just look from very far, but also, look into programming. How are we doing programming? Are they really, fitting what the community want, the community that we are saying that we are really helping? Or are we, as I said, helping, the donors? I think the other areas that we need to look into is, the capacity building within the global health, and also, other development, development projects. If we are, trying to, decolonize, whatever we are, the global health, then we need to see how are we doing, how are we building the capacity of those who are implementing projects? Are we building their capacity, to think in a certain way that they're able, to implement projects in the way that we want? If we can't really, start, asking our question how the trainings are done, we are still, just, using the term, but, not really, getting into the real issues here. Just, to end my topic, I think, we really need to borrow a concept that is being used in MDP, and MDP always, try to, they have a concept of trying, to understand the projects that have been implemented and why have the projects failed or haven't achieved. And the thing that, we need to start asking as a global health practitioners is also, trying to really, ask the question of, for whom and by whom are the projects that we are implementing. I think that's what I'm going to end my topic with. Thank you.
Thank you, Garang, for giving us your incredible journey from a young child up through being a child soldier, and then on with the help of so many, and with your own personal integrity and your energy for making the move from South Sudan to, my goodness, to here as a student at Emory. Thank you so much. Randy, I've introduced you, Dr. Packard, and I'm going to let you begin. I know that you are in charge of your own slides, so I'm going to ask you to unmute and also to take charge of the screen. So you are now the impresario for the screen. Thanks, Randy.
Thank you. That was a very moving talk.
Randy, can I interrupt and ask you to speak up, please?
Can you hear me now?
Yes, thank you.
I was just saying that was a very moving talk, and I just would point out that the civil war in Sudan was a product of colonial rule and the establishment of particular artificial boundaries that put those particular people together. So
and again, I'm going to interrupt you, Randy, and ask you to put your slides on slide view.
yeah, I'm going to.
Okay, thank you.
Can you see them?
Yes, thank you.
Okay. So I've been asked to provide a little historical background to the issue of decolonization of global health, and so to talk a little bit about, I guess, the colonization of global health. So I've titled my talk Colonial Entanglements because early efforts by colonial powers to improve the health of colonized peoples living in Africa, Asia, and parts of Latin America were linked to and laid the basis for many of the ideas and practices of early international health organizations. These legacies of colonial medicine, moreover, continue to influence global health today. So this map appeared in a report of a conference that was held in Cape Town in 1932, in Cape Town, South Africa in 1932. Representatives of several African colonial territories, British India, the League of Nations Health Organization, and the Rockefeller Foundation attended the meeting. The map shows air routes that crisscrossed the continent and connected Africa to other parts of the globe. The map was presented because it highlighted the potential threat of air travel to the spread of a yellow fever, a primary concern of the Cape Town Conference. Yet the map was significant in another way. Colonial medical authorities and representatives of early international health organizations traveled along these routes, collaborating in efforts to control sleeping sickness, malaria, hookworm, and yellow fever. They engaged in international meetings like the 1932 Cape Town Conference and consulted with one another. They published articles in the same scientific journals and formed complex research networks that stretched across the globe. Colonial officials moved back and forth, serving at various times in colonial administrations and then in international health organizations and back again. Most importantly, the early interventions of international health organizations were developed within colonial settings and to a significant degree were dependent on the coercive force of colonial rule. These interventions were also shaped by colonial ideas about the pathology of native populations and the inability of colonial peoples to improve their own health. All of these linkages contributed to the entanglement of colonial medicine and international health and shaped the subsequent development of international health efforts. If we are to understand the early history of international health, we must start with colonial beginnings. Colonial officials were concerned primarily with preventing disease outbreaks that would threaten Europeans and the economic base of colonial holdings by disabling colonial workers. Disease prevention often took the form of large-scale disease campaigns like the sleeping sickness campaign shown here from the Cameroon in 1933. The campaigns involved immunizations, vector control measures, or the treatment of infected individuals. Colonial health authorities also organized quarantine procedures when needed to prevent the introduction and spread of diseases. In some cases, disease prevention led to the institution of sanitary measures, particularly in urban areas. Both quarantine and sanitary measures were often enforced unequally, targeting colonized populations who were viewed by Europeans as sources of infection. These measures, as we'll see in the Philippines, could adversely affect the economic, and social lives of colonized peoples. All of these activities were conducted through top-down programs designed by colonial health authorities with little or no involvement or accountability to local populations. Moreover, they were backed by the coercive force of colonial administrations. Finally, little attention was paid to providing basic health services or addressing the social determinants of health. To the contrary, colonial social and economic policies often undermined health conditions. Accountability to those who were the targets of colonial health interventions was limited at best. Local Native authorities were frequently informed of planned interventions, mostly to enlist their support in carrying them out. But this interaction mostly took the form of issuing directives rather than soliciting comment or consulting about the advisability of particular strategies. Colonial health officials, empowered by the recent developments in bacteriology and tropical medicine, had faith in their ability to bring about improvements in the health of native populations, while at the same time, they viewed these populations as ignorant and unable to care for their own health needs. These views justified the use of coercive measures to enforce health interventions. This did not mean that local populations had no say in the conduct of campaigns, and I think this is an important point. Mary Wiebel, who used to teach here at Emory, her work on the history of sleeping sickness control activities instituted in East Africa by German authorities at the turn of the 20th century, clearly shows how the placement of sleeping sickness camps and the identification and treatment of Africans afflicted with sleeping sickness was greatly influenced by the action of local health African authorities. Yet it's important to distinguish the ability of colonial subjects to shape health interventions once they were initiated from the willingness or unwillingness of colonial authorities to seek advice and provide accountability. Throughout the history of international/global health, local populations have played an important, if informal and seldom acknowledged role in shaping health programs in the absence of formal channels of participation and accountability. While these patterns characterize colonial medicine in many parts of the globe, in the rest of this talk, I want to focus on colonial medicine in America's own colonial holdings. In 1898, the United States declared war on Spain and invaded Cuba and the Philippines. Following several months of sea and land battles, the Spanish sued for peace and ceded control of Cuba, the Philippines, Puerto Rico, and Guam to the United States in the Treaty of Paris. The United States had overnight become a tropical colonial power. Yellow fever was endemic in Cuba. In fact, the invasion of Cuba was stimulated in part by the belief that Cuba was an epicenter for epidemics of yellow fever that spread periodically through trade to the southern United States. To prevent yellow fever in New Orleans or Charleston, it was necessary to eliminate it in Cuba. Yellow fever also decimated US troops who landed in Cuba, like the one shown in this picture. If the invasion was to be successful, yellow fever had to be put under control. Responsibility for the elimination of yellow fever in Cuba quickly fell to Colonel William Crawford Gorgas. The Army sent Gorgas to command a hospital for yellow fever patients in Cuba in 1898. The following year, he was appointed Chief Sanitary Officer of Havana. Gorgas organized a military-style campaign against the Aedes aegypti mosquito that research conducted in Cuba by American and Cuban physicians had identified as the insect responsible for the transmission of yellow fever. Gorgas ordered his sanitation officers to attack the mosquitoes on two fronts, fumigating the houses of yellow fever patients and those of their neighbors to kill any mosquitoes that may have been infected by the patient, and the elimination of mosquito larvae by screening, covering, and oiling open water sources. While many Cubans objected to the intrusive measures initiated by Gorgas, especially because most Cubans had been exposed to the disease in childhood and were immune to it, nonetheless, the yellow fever campaign in Cuba was successful in eliminating yellow fever within a year. Gorgas subsequently repeated his Havana success, eliminating yellow fever and greatly reducing malaria in Panama, making possible the completion of the Panama Canal. A key to Gorgas's success was his administrative organization, but also his ability to control the urban spaces in which the Aedes aegypti bred, enforcing regulations aimed at eliminating breeding sites and fining those who disobeyed sanitary regulations. Colonial authority made disease elimination campaigns possible. This was a lesson that one of his assistants from Havana discovered when he attempted unsuccessfully to apply the same control measures in Laredo, Texas, without the same degree of authority or control. He wrote, "The Laredo epidemic has shown conclusively to the minds I'm going to get rid of that. The Laredo epidemic has shown conclusively, to my mind, that results such as were obtained in Havana in the suppression of yellow fever during the American occupation cannot be obtained elsewhere where the disease is widely spread without the undisputed authority and the means that were at the command of the government of intervention in Cuba. These powers in reality amounted to martial law." Why is this not moving? There we go. The U.S. also occupied the Philippines, where U.S. medical personnel were almost immediately faced with massive epidemics of cholera. They responded by launching campaigns aimed at sanitizing the population. The Filipino population came to be viewed as the primary source of the disease and a threat to the health of American troops and administrators due to their supposedly poor sanitary habits. As Warwick Anderson has documented, U.S. health officials were obsessed by what they saw as the Filipinos' indiscriminate defecation. American authorities also shared the widespread colonial view that colonial populations were incapable of improving health conditions without white tutelage. Henry Durest Phelan, a U.S. Army doctor who was assigned to Surigao in the Philippines in 1902, captured these attitudes when he observed that the ground beneath native houses was covered with filth of all kinds, of human excrement included. He viewed the Filipinos as lacking the capacity to improve their sanitary conditions without assistance. They appeared to be like so many children who need a strong hand to lead them in the path they are to follow. The American anti-cholera campaign in the Philippines also involved more drastic measures, including the burning of Filipino homes and entire neighborhoods said to be infected with cholera, as shown here. It also involved the mass burial of Filipino cholera victims, a practice that was offensive and deeply disturbing to the families of the dead. As one Filipino historian of the period noted, for the Filipino population, the American anti-cholera campaigns were an extension of America's brutal military suppression of Filipino resistance, which had resulted in the death of thousands of Filipinos. Oops. My point is that the success of colonial disease control campaigns and the emergence of as a central weapon of colonial medicine and later international health occurred in an environment in which social and political coercion was made possible by the existence of colonial rule and by colonial beliefs in the superiority of Western knowledge and technology and the ignorance of local populations. The disease campaign and the paternalistic and discriminatory attitudes espoused by colonial medical officials were adopted by officers of the International Health Board established by the Rockefeller Foundation in 1913. The initial goal of the International Health Board was to extend the foundation's efforts to eradicate hookworm in the American South to other countries around the globe where hookworm was seen as incapacitating millions of people. The board, which changed its name to the International Health Division in 1927, would become the most powerful and influential international health organization during the first half of the 20th century. By the time it wrapped up business in 1951, It had operated in 80 countries around the globe, fighting hookworm, bilharzia, malaria, and yellow fever. The International Health Division drew a number of its disease control program directors from amongst US colonial medical officers working in Panama and the Philippines, as shown in this chart and in this map, which shows the movement of these health officers across the globe. The movement of these colonial medical officers in the International Health Division's yellow fever and hookworm programs ensured that many of the practices and attitudes developed within America's colonial settings were embedded in the International Health Division's programs. This can be seen in the similarities in the design of control programs and in the attitudes of program leaders. For example, Henry Hansen, who worked under Gorgas in Panama and then took over the International Health Division's yellow fever campaign in Peru, observed, quote, superstitious, ignorant, and seemingly satisfied, the rank and file of natives of Lambaque, as elsewhere in Peru, were resentful of any effort to direct or change their mode of life. Similarly, Samuel Darling, who directed the International Health Division's hookworm program in Malaya, noted, most of the Tamil workers in the federated states come from the Madras presidency in southern India and are the same and are in the main ignorant, superstitious, and servile. Probably not more than 5% of them are able to write their names. While it is true that Tamils are hard workers, it is also true that they are almost entirely lacking in ambition. Docile, unstable, apparently quite incapable of administering their own affairs, and either dispatch or intelligence, they constitute the white man's burden. Similar disdain for local populations was captured in this observation by Victor Heiser, who headed US colonial health programs in the Philippines and later became responsible for the Rockefeller Foundation's hookworm programs in Asia and held the presumptuous title Director of the East. Orientals could not be sanitated. He always lived in filth and squalor. To persuade him to live in any other way was hopeless. All efforts, therefore, should be concentrated on making living conditions safe for the European who was obliged to sojourn in his midst. The International Health Division organized hookworm campaigns across the British Caribbean, Central America, South and Southeast Asia. Outside of Latin America, almost all the countries in which the foundation operated were under colonial rule. The campaign centered on the mass administration of vermicides to rid the population of hookworms. The International Health Division claimed to have cured thousands of people through their work. Yet to sustain these gains, the International Health Division needed to convince populations to wear shoes and use latrines to prevent reinfection. Unfortunately, this prevention work received much less attention than the International Health Division's curative efforts. Unlike their counterparts working in the American South, International Health Division medical officers had little patience for sanitary work and made no attempt to understand the perceptions of local populations and the conditions under which they lived and how they might impact their adoption of sanitary measures. In Trinidad and British Guiana, sanitation efforts ran into local resistance to building latrines, both because the latrines were expensive to build and because in some places they conflicted with local cultural attitudes regarding excreta. In Costa Rica, local populations rightly complained that latrines attracted mosquitoes and led to increases in malaria. In Mexico, Foundation officers viewed the failure of Mexican peasants to wear shoes as a kind of moral failing on their part, whereas in fact it was due to their inability to buy shoes, to afford them. This misunderstanding reflected the Foundation's general disregard for the underlying social determinants of health. The failure of IHB officers to understand local attitudes and conditions reflected a colonial disdain for the abilities of local populations and the absence of efforts to engage or seek their counsel. It reflected a lack of downward accountability. To make matters worse, the vermicides used by the Foundation could cause blindness and death. As historian Steve Palmer has shown, between 1914 and 1934, the IHD documented over 200 deaths from oil genopodium intoxication. More than 80% suffered by children 12 years of age or under. The foundation's initial reaction was to deny that the toxic drugs had caused the deaths, yet the foundation had evidence of the drug's toxicity, particularly for children under 12. And by 1926, pressure from below in the form of protest by Colombian physicians who were involved in running the program in that country eventually forced the foundation to acknowledge liability for some of the children who had died and to pay compensation in at least one case. It was a rare example of the foundation being made to be accountable to a population being treated. And it highlights the importance of resistance from below to making international health organizations accountable. The Rockefeller Foundation also funded the creation of a number of schools of public health around the globe. Two of the earliest were the London School of Tropical Hygiene and Medicine and the Johns Hopkins School of Hygiene and Public Health in Baltimore. These schools were intended to be centers for the development and dissemination of the new public health based on the application of scientific methods and principles informed by the new sciences of bacteriology and parasitology. Johns Hopkins opened in 1916 with William Welch, the first dean of the School of Johns Hopkins Medicine, as its dean. The Johns Hopkins School attracted a wide range of students. While Welch sought to train young medical researchers, the Rockefeller Foundation used the school to train its present and future staff members, award advanced degrees to experienced men in the field, and bring the field staff for specialized training courses. The school also served another purpose. It trained international students who were brought in with fellowships and who received an education in hygiene and then returned to head up health programs and become faculty at local schools of public health in their home countries. The schools of public health funded by the Rockefeller Foundation became places where models of disease control and public health, forged in colonial settings and replicated in disease control projects across the globe, intersected with scientific practices, methods, and knowledge of the new science of hygiene. This conjunction of colonial field experience with public health education can be seen in the short course on parasitology that Frederick Soper took at the Johns Hopkins School of Public Health in 1923, after he joined the International Health Division. Soper, who would go on to lead the hookworm and yellow fever campaigns of the International Health Division, became a major advocate of disease eradication and eventually became director of the Pan American Sanitary Bureau, which was later the Pan American Health Organization. As part of his parasitology course, he claimed to have taken a class on yellow fever control that was taught by Colonel William Gorgas. Years later, when Soper was sent to Brazil to combat yellow fever and malaria, he was met by Brazilian counterparts who had been trained at Johns Hopkins. As Americans and foreign nationals who were trained in the new schools of public health took up academic and public health positions around the world, they became part of an international community of public health workers who shared a common set of ideals and practices. In this way, disease control programs forged in the crucible of colonial rule during the first decades of the 20th century were fused with and became part of the science of hygiene. In this form, they were easily transferable to non-colonial settings and became central to the practices of international health. In conclusion, disease elimination campaign perfected in American colonies and then transported by the Rockefeller Foundation across the globe became a central strategy for international health programs after World War II. The culmination of this strategy were the efforts to eradicate malaria and smallpox in the 1960s and 70s, and more recent attempts to eradicate polio, guinea worm, and malaria yet again. With the exception of the brief rise and decline of primary healthcare movement in the late 1970s, international health continued to reproduce policies and attitudes that had their origins in colonial medicine. These included top-down patterns of decision-making, faith in the ability of biotechnologies to solve complex health problems, the tendency to discount local knowledge, an emphasis on the upward rather than downward accountability in global health, and a lack of attention to the social determinants of health. These are all part of the global health colonial legacy. Thank you.
Thank you, Randy.
There, I'm back.
All right, there we go. You'd think we'd be more facile with this after
Yeah.
practice that we've had over the years, over this past year. Thank you, Randy, and many thanks to you, Garang. Garang, I wonder if you can, there he goes. I wonder if you can put on your video. Thank you so much. Just one question before I get to those that have been submitted by people either before this presentation or during the presentation. Garang, I wonder if you can give more perspective in terms of the historical background that Randy has given and how you saw that played out and see that played out even now in South Sudan, either by Americans, Europeans, or other expats as they come to South Sudan to do good, and whether you think, or your perspective is that in some ways reflects the same historical background, the same historical permutations, the same historical impetus that Randy has described during the colonial period.
Thank you, Dr. Deb. And thank you, Randy, for an insight presentation. As a as a little background of South Sudan, we are actually caught in between,
Yeah.
and the legacy of the colonial history actually still play within the country. And if you see part of it is it's us South Sudanese, but it's still the history really is still play on how the entire country is set up now. We are very much divided now on a tribal line.
Mm-hmm.
And it has to do because after the British left, the country was left under Arab, and the only way to maintain power was the division within the communities. And our the country is set up of tribe, and every tribe now, if you look at it, one tribe wanted to be the dominant over the other tribe, and that's how the country is struggling and still struggling within the current time. In regard to what to the question that you asked, there are expatriates who are really doing good, and I would say much of it has to do on it has to do on the value of organization, and also the funders that are behind also the organization, because from my first experience, much of the global health projects, or maybe the development projects that are being implemented in South Sudan, are purely driven, by it's more of the top-down approach. It is where the knowledge is, we see the knowledge, coming outside. So we are not to use, I don't want really, to create a perception, but to some degree, if you look at how projects are being implemented, there's so much of what Randy is saying that, we see ourselves at some point, being acted upon, and to some degree, being an object, because, we really don't, there's nothing much being, communities really don't contribute into the projects that are being implemented. Though most of the people wanted, to do good, you might go in, you might be hired by an organization. You really wanted to do good as, individual. But if you have, a blueprint that guide on how the projects are being implemented, it's always, become difficult. So I think that's, what is happening. But there's also, some sort of narrative now, within, non-profit world that, they wanted, to involve the local communities, and now they are trying, to partner with local organization, community-based organization. But it's still, these community organizations are acting, they are just only implementers. The project's design is done, way beyond, where you really don't know.
Mm-hmm.
Yeah, so that's, basically what I'm, that's what I'm seeing. There's an element of, doing good, but, on the process of doing good, you still do the same thing every year in, year out. And you start asking yourself, if you are doing the same over and over, then are you really helping communities, or also, you're pushing them in, in the defeat? So that's, that's what I'm seeing, happening. It's still, guided by the top-down approach rather than, the bottom-up.
Thank you, Garang. I know there are lots of comments and questions, particularly for you, Garang, and we will get to those in just a moment. I wanted to ask Randy, one that came in during your presentation that I thought would give you an opportunity to give us some perspective, both historically and currently. The questioner says, I recently read King Leopold's Ghost and was struck by the fact that 2 African-American missionaries tried and failed in the early 1900s to bring international attention to the atrocities happening in Congo, which is now DRC, because they had no voice in either Europe or the US. Their reports were not believed simply because, excuse me, I've lost it, simply because they were Black. Do you feel that the same sensitivity to colonialism that the current African diaspora has now is still being muted or underrepresented in global health departments in schools of health in the USA and Europe?
I guess the simple answer is yes. I think that what's interesting about that case in the Congo with the missionaries being ignored, I mean, you can argue it is because they were Black, and it certainly disempowered them, but there were so many interests at stake, that no one wants to listen. I don't think it would have mattered if it was a colonial Belgian who came out and started pointing these things out. There was too much financial interest in stake for the Belgian government, for the international community to listen to that sort of thing. So I think there's both a racial, dynamic going on there, but also a power differential and an economic differential that's playing in and still playing into how global health is functions and organized.
Thank you. I'm going to stick with you, Randy, and then come back if I can to you, Garang. But if you have comments on any of these questions, please do respond. I'd appreciate that. Because some of the questions that have come into you are very specifically about your own experience, which I certainly understand, and I want to give you the opportunity to share with the group. Just following up, Randy, on the response that you gave, public health and medical institutions, including Hopkins, Emory, I might add, with 40% international students in their MPH program, have often failed to recognize their own white colonialistic rules in the communities in which they reside, let alone teach about it. The one course where I was introduced to the concept of decolonizing public health was in their Indigenous health course, when we discussed decolonizing methodologies as they applied to working with Indigenous communities. Can one of the first steps toward change on an academic side be to change the public health curriculum and include honest recognition of existing colonialistic public health practices and organizations? And parenthetically, and not in bold, but I perceive it to be in bold, including those practiced by faculty themselves.
Again, yes. I mean, I certainly at Hopkins, and from what I remember as working at Emory, that but particularly at Hopkins, public health education is, as one, certainly international health was, as one of my colleagues in international said, it's a methods bazaar. And basically you're taking a series of courses in order to develop capacities to do certain things, and running, community trials to evaluating programs. I mean, a whole series of things, and you do statistics and you do epidemiology and all things which are important in public health. But there's very little space in the curriculum to sort of step back and look at the big picture and ask the important questions that whoever asked this question asked about, what are we doing, and to what extent are we actually creating a form of public health that is responsive to the needs of the populations we're actually supposed to be serving. And to what extent does anything we do actually include forms of accountability that are accountability down to local populations and not simply accountability up to donors and program planners. I don't think there's nearly enough concern about accountability. And I need to say that when I say accountability, I don't mean a sort of colonial form of saying, this is what we're going to do and we've done it, but actually, full participation in the planning and development and assessment of programs on the ground. Now, to do that kind of accountability, I mean, what you run up to against is these sort of inequalities in capacity. And how do you actually, you need to have a sort of situation which people on the ground have the power in terms of knowledge and resources to, forcefully put forth their vision of what needs to be done and to actually negotiate on equal terms. And that means, you need to do a lot of things which we're not doing, but it's capacity building in research, capacity building in education, but taking seriously the views, understandings of local population and building that in rather than just sort of, constantly sort of producing these programs and sending them out. And, I was at a meeting in which there was a researcher who is well known for developing participatory forms of programs, and was very much concerned about developing programs that actually enacted downward accountability. And my simple question was, well, who do you report to when, to your reports of your findings? And it was clear, there's people who fund this stuff and they need to be, the system is set up in a way that, makes it very difficult to achieve this kind of accountability. So I'm stopped there. I'm sorry, I'm rambling on.
Well, that's what we expect from professors. No, sorry, Randy, that's not true. We do have several questions that were submitted prior to your presentations. I've taken the prerogative of changing them a wee bit to reflect what both of you have said. But let me read a couple of them and see if we can get both Garang and Randy's perspective. And rather than this being, okay, Randy answers one question and Garang answers another, please do let both of you interact. And Garang, if you want to challenge Randy, that would be great. And Randy, if you want to come back to Garang, that would be wonderful as well. Big question. How can we possibly decolonize public health when our economic policies, which control our country, are based on exploitation? So lots of words, and it's a question that was asked, as I said, a priori before this session. But any insights from either of you?
Well, Deb, this is really, it's one of the biggest questions, and I don't really, I have, an answer for it. And, based on what Randy has just said, how these programs are, top down, and if you wonder sometimes, who are you reporting to?
Yeah.
This is the nature, because, it has an element of economic, if these big companies that, funded, research program or the public health program, if they are under it and they wanted to meet their interests, and their funding drive the kind of the programs that we are implementing, and that's become an issue. It's become a bigger issue on how do you change, how do you decolonize here, when your hands are, barely tired by this, by the people who are, funding you. So I think, the narrative here, or, the conversation is not just about, it shouldn't be, like those that are, like, we, academician and those, organizations that are implementing. There has to be also, like a conversation that involve, these big companies that are also funding.
Uh-huh.
Otherwise, whatever we are doing always, it's purely, being driven by their own interest. So I think that's,
Mm-hmm.
No, I agree completely with that. And I mean, it's sort of a question of how big a bite you want to take and what you want to take on. I mean, a number of years ago, I went out to Seattle to talk to the Gates Foundation about malaria, and I had dinner with Kent Campbell, who some of you may know, who used to hang around Emory, and knows a lot about malaria, and the executive secretary for Rollback Malaria. And I walked into the restaurant, and Kent stood up and he said, "I want to introduce Randy Packard. He believes you can't control malaria without social revolution." and I thought that was funny. But there is this question is sort of like, there's the huge question of global exploitation.
Yeah, right.
Do you have to start there? It's maybe that's where you need to start, but I sort of like go down a peg and say, well, I really don't know how I can actually deal with that in any kind of practical way, and say, all right, you need to deal with some of the more operational kinds of things. And I don't mean sort of, the kind of technical fixes, but I mean, operational in the sense that I was saying, is that how do you ensure that there is an equitable system of accountability in global health? That's something you can take on, all right? It's difficult, and there are a lot of steps to doing it, but at least it's something I can imagine creating a strategy for without, sort of mobilizing in the streets.
Yes, without revolution. I think that's exactly what you said at the very outset, isn't it? That local accountability, your perspective of development and public health is that of a local public health practitioner, activist, household leader, community leader, and a question that several students, or that several have had in different forms in the chat box, is how do younger students who are entering the workforce now, younger practitioners, younger public health scholars who are entering the workforce, challenge the older, more experienced professionals in the field? I think it's basically, okay, are any of us white hairs listening to young people? So how can we, let's think about how we incorporate that in our own public health practice and our own academic courses, research and practice. It's not a question, but it's a comment that someone had. Any comments about the new young generation coming into global health and inculcating much of what both of you have said for their future careers in public health and in global health? Learning from you guys.
I think, Deb, I'm also one of the incoming, generation.
Yes, you are.
So I don't have much, to the question, but I think, it's all come onto you, and Randy. How do you guys, facilitate us, those who are really coming in? And I think, it has to start, with the conversation like this one, where, where the loop is, and how this young generation, can come in and fill, the gaps that has been happening, all these inequalities. So I feel, you are the one, setting up the path for this incoming generation. If you start telling us what is really need, the truth about what has been happening.
Right. Well, we need to listen. I must say that it reminded me of a class I taught at Emory on history of international health and development, I think it was called. And after one of our sessions, And it was sort of along the lines of this talk today. I mean, there was a lot of that. She said, this class is really important, but I don't know what to do with this knowledge. And I said, well, how come? He said, well, I'm going to go out and get a job at the lower levels of some institution. She worked actually in care, and she'd been in the field for quite a while. And I'm not going to really be able to sort of shake things up if I want to keep my job. And then by the time I get to the top of the ladder, it'll be so natural to do what I'm doing that I won't question it then. That was a very depressing conversation when I thought about it. But there was a certain truth to that. And I think that one of the places where that needs to be shaken up is in schools of public health. I mean, I think that schools of public health need to start training people in ways that take account of all these issues and actually make it part of the curriculum. I mean, the curriculum does, in most schools of public health, just doesn't pay enough attention to these issues or problematize these issues and say, okay, so how can we actually deal? What can we do better and how we do it better? It's not going to be with better epi courses and not going to be better biostats courses, right? Or even courses on, refugee settlement. You're really going to have courses that interrogate the fundamental structures and get people thinking along those lines. But, you're still going to have to deal with the power structures that operate within international health that are outside of the schools of public health and operate in the World Bank and operate at USAID. I mean, it's a big lift. So I hate to be, sort of negative about this, but I think it's a real problem in how you integrate these new views into the system. But I think the first step is to be aware that they're there and you need to, and it's a problem.
Okay, thank you.
Dave, there's someone who asked, what made me come to Emory?
Yes, I was going to get to that and specifically asking you now, there was a question, what made you choose to come specifically to Emory for your endeavors? Good question. And the follow-up question, which you've probably seen as well, how did you get the strength to leave the life of a child soldier at age 16? You mentioned a role model, but did you have any other support? Your family, for example. So,
yeah.
It's good to take us from the conceptual, the historical to the specific as you have lived your life over the last 30 years. Thanks, Garang.
Yeah, thank you, Dave. And, okay, it was, like a hard journey, being a child soldier.
Yes.
And, it's, as soon as I joined, like being a child soldier, I was in the middle of, every day, as I mentioned before, is, it's full of grievances, like you lose the loved one every day. And so at some point, like I was, as I wanted, like my intention or, the mission of what I wanted to do was not being fulfilled, So I had this guy who was, my immediate boss. And the way things work in guerrilla is that, if you always have, the boss, you do things for the boss, you wash their clothes. When there's journey, you always carry, their belonging, if as soon as you reach to the station, then you start cooking for them. But that was completely opposite to my boss. And my boss, actually, he was fairly learned, he knew, the reason why he was there. And this is the guy who started, framing about the education, that if you really wanted, like to be, if you wanted to be good to the society, then you need to go to school. And there is, he was telling me that, look, there is a time that there's a fighting which is going to come. And this fighting will not be, like we won't be holding guns. It's the fighting that you will be in the offices, and then you will be holding a fan. And that needs someone who is educated. So if you wanted, to fight, a coming, fight, then you need, to start going to school. And that's how, all his word and how he was supporting me led me to go to school. And he actually, like facilitated me, and he told me, please, as soon as you go bury your gun, and this might be, the last time that you will see me, And that was really, it was real. That was the last time I saw him. And that, our last talk actually gave me a hope that, I need to fulfill. This was another mission that was given to me by him that I need to fulfill. I need to go to school. That's, what kept me pushing until, I finished my education. Where I was, there was no any other support. My family was not there. I haven't, since I left in 1980, around 1988 and 1989, I've not seen my family until 2007. So it was about, about 18 years I haven't seen my family. Neither do they even, know that I was alive. So there was no, other support, to fall behind, in time of difficulties. But, my boss was the one who kept me, moving. So coming to the question of how, I have choose Emory specifically, or how I end up here, I was stuck in between because I was working for Carter Center and for the period of some time. And that, led me to really, be closer with communities and trying to understand them. And I realized that, the problem that community were facing were more than just, what we were doing. There were other factors which were playing. And I thought, I wanted, to go back to school. And while I was working for Carter Center, I was, blessed, to have kept the money. And also my bosses were people who wanted, to see those who are, South Sudanese actually take up the program. So he advised me, to keep the money safe if I want to go back to school. And I did that. And after 6 years, I went back to school, study, and then came back, work for a local organization because I wanted to be closer to community. As I was working for them, I was not the question that I had in my mind, I was not answering them, We were doing, we were implementing projects after project, year in, year out. And it's just the same program, We are doing emergency program. And some of these areas are relatively, peaceful. So I started, asking myself, well, something must be wrong here. And I might need, a different skills sets, that will help me to understand more. Why are we, doing what we are doing now? And yet we are not, there's nothing that we are really realizing. So I applied to different universities. And since I was working, with the Carter Center, I had so many friends who were also, Emory graduate. And I tend, to know Emory more than any other school that I had applied to. And also having given, a partial scholarship, which was, much more than what other, school have offered, that made me come to Emory. So that's how I ended up, at Emory with the connection that I had, and also with the projects, MDP was completely unique. It was a hand-on based, master program. And I thought this is what I need. I don't just want, to be, to get stuck in a theoretical kind of, master's program, but at least, a hand-on master program. So that's how, I end up, being at Emory today.
Well, we're delighted that you're here, Garang. Fantastic. And thank you for coming to Emory. We are rich because of your presence.
Thank you, Deb. I'm also, I'm rich, and I feel like, my being here also is helping me to support people back home. And you know what I'm talking about.
Yes, I do.
Thank you.
Pardon me, I'm having a hard time catching up with all of the questions. Could you read one or two off while I continue to channel through them?
Yeah, sure. This is one question that came up for Randy. So you spoke a lot about some of the histories of the colonial influence on infectious diseases, sanitation. Are there parallels for non-communicable diseases in terms of colonial histories, such as diabetes programs, nutrition programs as well? Or is it really comes strictly from the infectious disease field?
Yeah, I mean, there was relatively little attention under colonial and even early International Health Organization work on non-infectious diseases. And I'm trying to think, certainly diabetes wasn't a concern, obesity wasn't a concern. Even, it wasn't until, the last decade or so that people began to realize that there's a, an epidemic of cancer going on in many African countries, because it was, hidden from vision, for a range of reasons. A, you don't have people trained as oncologists, and B, you have all this overlay of other diseases which are grabbing people's attention. So, that there is some, chronic, there is some attention to occupational diseases, particularly in the mining industry in Southern Africa. You do get that. So silicosis, and various other types of respiratory diseases receive some attention. All of it, within the context of how we're going to maintain profits, and what is the, the way to prevent it to the extent that we're be able to maintain our workforce. Anyway, I've written a lot about that. So, but the simple answer is that, there wasn't a lot of attention paid to non-infectious diseases or to chronic illnesses.
Okay. Again, I'm scrolling through, so appreciate your patience. Perhaps one last question that I think comes back around to several of the issues that both of you have raised. It follows from the presentation, Randy, that you made on, quote, the US desire to invade Cuba to control yellow fever. Is a romantic notion that obviates the land grab in the Caribbean and in the Pacific. What was not presented was that those lands were exploited by Spaniards, and they didn't improve the quality of life of the peoples that they colonized. In Africa, the Portuguese colonies, it wasn't much different, especially Mozambique and Angola. The ministries of health and education there were meant for the benefit of white colonizers and not for the Black population. I think we may be doing slightly better, but we are still imposing our ways of doing public health and development without contextualizing where this work is being done, nor with large input from local communities and populations. Can we realistically expect things might be different someday?
Sure. We can always hope. Look, I mean, my presentation covered a certain period of time.
Yes.
And really ends by World War II. And I suggest that, and I think rightly, that there are legacies that we still see in place. But there are programs, there are things going on that are moving it in the other direction. There are primary healthcare movements, like the Jamkhed Comprehensive Rural Health Project in India, which has been going for years and which has been able to expand and cover more and more people and very participatory. The major problem of a lot of these programs is going to scale, being able to take something which is highly successful in dealing or building sort of participatory development in particular places, and then expanding that outward to larger populations. So it's not like, there's a barren landscape. And so, part of it is sort of acknowledging those successes and figuring out how you replicate them, how you fund those, and the funding is a real issue because so much of the funding goes into, programs that are based around technologies. And whether it's distributing vitamin A capsules, or it's immunizations or bed nets or what have you, and that leaves less room for participatory kinds of things because it's sort of a packaged health intervention that you just sort of throw in there. So, but I don't want to leave people thinking that there's it's all a barren wasteland. That there are things going on.
It is not a barren wasteland. Many students and others on this session in this webcast. We have wonderful role models and leaders for the future. So I know you and I and Parmi and others look forward to continuing to work with Garang, his colleagues, and all of our students. thank you for all of the participation. Parmi, I'm going to turn it back to you. Thank you, Randy, for
You're welcome. It's fun.
giving us the historical perspective and on colonial entanglements. And Garang, thank you again for your personal perspective and insights about working, about being a student, about being, about your life, and about now the work that you're going to be doing back home in South Sudan. Parmi, I turn it back to you.
Yeah, well, just to wrap things up, just yeah, again, a great thanks to our panelists. I think you raised some really big issues that that are important issues that I think is going to take really all our responsibilities to really work on untangling these. And yeah, it's a big task, but I think that's really the point of this discussion is to really start getting into these, and the work is definitely just begun. So just some logistics. We're going to be, if you registered for this, you'll be getting an evaluation. Please fill that out. You can also note specific topics that you'd like us to cover in future webinars. And we have a breakout discussion today at 4 p.m. Eastern Standard Time, which will be a chance to, in a smaller groups, to really talk about some of the readings we had posted and to really get into these issues in a bit more detail. So I think that'll be a great opportunity if you'd like to continue this discussion. And then this webinar will be recorded and will be posted on our website, and you can also go there to register for the next event. So with that, hope you all have a good day, and we hope to see you next time. Thank you.
Thank you.
Thank you.
Thank you, everyone.